4, 3, 2, we are live.
Okay. Good evening, everyone. We are back with yet another session in the PG Teaching Spine series. And this time we have a topic which is very important both from the medical side as well as the surgical side. And we have just the right teacher to guide you through this topic, Dr. Tikoo, Dr. Agnivesh Tikoo. He's a consultant spine surgeon from Apollo Hospital, and he has also finished his FNB Spine Surgery. And over to Dr. Agnivesh, sir.
Thank you, Rohan. Thank you very much for this opportunity. And I will start sharing the screen without any delay. Yeah, I hope it is visible. So
yes, sir, your screen is visible, sir. Please go ahead.
So in this talk, basically, I will try to cover up from basic to the surgical part. You can stop me at any point of time you want to highlight any point, or if anybody has a question. It's a vast topic. I've tried to sort of make it concise so that we can understand, and then obviously you can build upon it as and when you sort of read your own book or you sort of read on a case-to-case basis. So we know that bone is a dynamic structure and primarily has two components. One are the bone cells and second is the bone matrix. So bone matrix is basically primarily the mineral, which is the 2/3 of the dry weight of the bone. The bone cells are osteoblast, osteoclast. We all know them. We have read about them. And bone matrix, as we discussed, the primarily is the crystalline hydroxyapatite, which the formula for which is an exam question, and you should remember it by heart. Now, if there is a vitamin D deficiency, it causes defective mineralization, which leads to osteomalacia or rickets in children. Or if everything is lost, that is what is called as osteoporosis. So you also should know the difference between osteoporosis and osteomalacia. So in males, the bone formation and loss are equal, and there's a very tiny sort of negative balance which happens after 45 to 50. But as compared in females, till sort of their perimenopausal time, there is a significant negative balance of the bone which happens. And this is the time when they mostly become osteoporotic, which is 5 to 10 years around the menopausal period. And females are at higher risk of losing their peak bone mass as compared to males. But the second fracture risk in a male is similar to a female, which means if a male suffers osteoporotic fracture, his tendency to suffer a second osteoporotic fracture is similar to a female. So what is the increase in fragility fractures? So each standard deviation increase in BMD loss, which means from -1 to -2, or you may say -2 to -3, is associated with 1.3 times increase of fracture risk. And the mortality rate of an osteoporotic fracture is also very high. Most of the people, not most of the people, a huge number of these patients are not able to make beyond their first year. And 80% of them can never sort of go back to their activities. So that is why this is labeled as a silent killer, not a silent disease. So by definition, it is a skeletal disorder characterized by low bone mass and microarchitectural deterioration, which increases it to a fracture risk. There is something called as osteoporosis care gap, which means that the physician is unable to realize osteoporosis as a diagnosis in many patients. And because of that, they left untreated and suffer fractures in the later age group. So the Osteoporosis can be primary or secondary. The primary is type 1, which is post-menopausal, or type 2, which is senile. Type 1 primarily affects the trabecular bone, and type 2 primarily affects the compact bone. Secondary osteoporosis can be because of multiple disorders. It's something you should keep in mind if you have an unexpectedly low bone mineral density in a patient. So you should evaluate them for secondary osteoporosis. We all know that bone density by DEXA, dual energy X-ray absorptiometry, is the gold standard. We measure primarily at 3 places: the spine, the hips, as well as the wrists. And this gives us a T-score, which helps us to quantify the fracture risk. Now, WHO tried to simplify this, and they came up with something called as T-score, which was after Dr. Thomas Kelly. And based on this T-score, we categorized the bone mineral density normal as -1 to +1. Osteopenia is -1 to -2.5, which means -2.4 is the upper limit of osteopenia. If it is -2.5, it is osteoporosis. And severe osteoporosis is -3.5 and below. Sorry, there is an error in this. Or any score of -2.5 with a fragility fracture. So who should undergo a bone density? A female above 65 and a male above 70 is a primary candidate for bone density. But if you have a high-risk patient who is on steroids, who has got multiple comorbidities, who is diabetic, thin, then you may consider doing them early. But you should sort of not do it randomly and consider doing it after 50, 55, because that is where it correlates more with the actual bone density of the population. Other factors which you may sort of want to consider is like if you see a Dowager's hump, a round back, which would suggest osteoporosis, and again other risk factors which we discussed about. So DEXA primarily has 2 scores. It has got a demographic information of the patient. Then it has got scores which are T-score and Z-score. So T-score is matched with a young adult, same sex, and Z-score is a age-matched score. So you also have a graph which shows a sign wherein you know if it is in red, it's osteoporosis, yellow is osteopenia, and green is a safe zone or the normal bone density. So if your Z-score is less than -2, then secondary osteoporosis should be ruled out. So this is very essential to remember. If you have a very, very low Z-score, you should rule out secondary osteoporosis. Again, there are 2 measurements. The spine and femur are central, and the forearm is the peripheral measurement. The heel bone densitometry is not an accurate way. It's a screening tool. It does not mean anything. If your bone heel density is low, a patient comes to you with a low heel bone density, and you will have to get a confirmatory test done, which is a dual energy X-ray absorptiometry or a DEXA scan. There is something also called as qualitative CT, which is a 3-dimensional measurement of bone density. What happens in DEXA, it is a 2-dimensional sort of a study, and a lot of osteophytes and other things can cause shadows which may be interpreted as good bone. So in QCT, you can measure the bone density more accurately, and it will help you to measure the volume of interest directly. Like if you want to know the bone density of a trochanteric area, so you can directly measure that volume and know what is the bone density at that level. It is also shown to be better predictive of fracture probability than bone density. The problem is that it is not available everywhere. So DEXA also has limitations. It cannot differentiate between osteomalacia and osteoporosis, as we discussed, or even other bone diseases. Even if there is a tuberculosis which causes bone lysis, so it will interpret as a low bone density or osteoporosis. It cannot differentiate between diseases. Like in this case, you see the patient having a hip replaced done. So bone density will not be able to measure the T-score and all. And see this on the left, there are multiple osteophytes in the spine and your bone density seems pretty good. But when you see the bone density of the wrist, it's minus 4.2. The hip is already having a fracture. Spine has got severe degeneration, maybe a couple of fractures also. So this is the true measurement of the bone density and not the other two scores which we just saw. So because of these fallacies, there has been a tendency to move towards the clinical indication of bone density or clinical measurement, which comes by the name of FRAX, which is the fracture risk assessment tool. So it is gives a 10-year probability of hip fracture and major osteoporotic fracture. So you have to fill a form like this. And when you fill this form, it gives you a probability of fracture. If it is more than 3% of hip fracture and more than 20% of major osteoporotic fracture, then you should consider giving the patient anti-osteoporotic therapy. For any patient of osteoporosis, you should at basic do a CBC ESR, serum calcium levels. Either you do ionized calcium or you measure the calcium along with albumin and do the albumin correction of the calcium. You should do a serum alkaline phosphatase, PTH, vitamin D. Metabolic workup, basic, you should check the history and see if the patient does not have any liver disorder or kidney disorder or any other thing. So all these should be. Thyroid is a common cause for osteoporosis, so it should also not be missed. So vitamin, this calcium test. So how do you do albumin correction? You should remember this formula. So total calcium what you get in blood plus 0.8 times the difference of 4 minus albumin level. It's a bit complex, but once you start doing this calculation, you will get the right value. So let's believe a patient has got a calcium of 9.8, which is normal, but his albumin is 3. So when you correct it, it becomes 10.6, which comes in hypercalcemia range. So you may get misleaded by only knowing the total calcium level and not correcting it with the albumin level. Vitamin D, whenever you advise for total vitamin D, which is vitamin D2 plus D3. You should not ask for serum 125 hydroxy vitamin D, because that is not something which you look to measure in a clinical scenario. There are other advanced investigations which are like bone formation markers like P1NP, which we measure clinically, or CTX, which we, or beta cross labs, which we measure as bone resorption markers and help us in clinically monitoring the therapy. So what these markers do, you cannot interpret a bone density quickly. So you have to give a gap of 2 years before you repeat the bone density. And these markers within 3 months can help you to understand if your medicines are working or not. They can also be used as a guide to monitor therapy, or they can be used as a tool to know whether the patient is compliant to management or not. So non-pharmacological management ideally should be started in the young ages only, because 30 to 33, 35 is your peak bone mass, which means that is the best time when your body will have your maximum bone density. The higher the peak bone mass, the more bone stock you have to lose. So exercises, good lifestyle are very essential. So you don't want to intervene at an elderly age. You want to intervene early so that they have a good peak bone mass, good bone to lose, and have enough to last their remaining life. So daily walking more than 45 minutes is recommended. Brisk walking is something which you should sort of consider. Every healthy patient should consider doing it, whoever can. Weight bearing exercises as per age, whatever you can do should be do. Good amount of calcium. The regular dietary intake varies with age, but 800 to 1000 is perimenopausal what you are looking for in diet plus tablets. It's not only tablets. In younger age, I don't prefer giving tablets to the patient. Natural sources are better. Avoiding alcohol, smoking are the other things which you can do to protect your bone density. So, Rohan, you want me to stop here to take questions, or we can go ahead and finish it?
We can, but there's just one question which I would want to ask you, and maybe you can tell the residents about it also. So a lot of times what we have is, when we have these elderly patients who come to us, the fracture is more so at the thoracolumbar junction, and that time we have an L1 fracture, either which is healed or maybe which is fresh. So now when we are actually calculating the bone mineral density at that point in time, it gives us a false value, in the sense that, like you said, it comes out as if it's a better, she's better off than actually what she is, because I think she would be more porotic. So in that point in time, if you have to, like we were told that, what you should do is you should just take the arithmetic mean of those three other vertebrae and then calculate it. So what are your views on it? Or do you still go for the third parameter, which is the wrist? Or how does that, come into your practice?
Yeah. So in spine, if you have such a scenario, you can look at the other three scores. If those three scores are less than -2.5, you know that it is osteoporosis. Even if L1 is showing -1 and then deviating the whole mean towards osteopenia, it doesn't mean, because once you have a fragility fracture, it's a proven osteoporosis. So you don't need any other diagnosis for having the means once you have such a scenario. So I would look at other scores. Sometimes even L1 is fractured, but other levels also may have severe osteophytes and all, or degenerative scoliosis. So your DEXA reading may not be accurate. So you have to look at the complete DEXA picture and also the clinical scenario. Like if fragility fracture is there, high risk is there, patient is on steroids. So all these things you need to consider.
Yes, sir. Thank you. I think we can go ahead with the medical management and then come back to the residents.
Okay, fine. So I want to just highlight a few points on medical management. It is very essential that all of us as orthopedicians should know the medical management of osteoporosis, because we know the criticality of our surgery, what we do. We cannot leave it to somebody else to sort of take charge of this osteoporotic treatment, because we know what is the urgency of the treatment and what is the sort of preferential thing which you want to do or which you want to give to the patient. So we should all have the clinical scenarios and clinical knowledge in mind, so that we can apply it and treat our patients as per whatever we think is the right way. We think means in respect to the surgical scenario is the right treatment for the patient. So we discuss these osteoporosis. Let's look at the turnover scenarios. So what happens is that, let's have a look at a sort of a tank of water where there is a good flow in and good flow out. This is happening when you are young. So your bone formation is also good, and then sort of your bone loss is also at the same level. Your formation is higher than loss, so you build up the bone mass. So if you have a very high turnover scenario, like in perimenopausal area where the bone loss suddenly increases, if you are able to plug that leak, you will be able to fill up the tank, because your bone sort of formation is still not that bad as compared to a senile patient. But on the other hand, if you have a very low turnover, like patient in 80s who has got a very low bone sort of formation and very low bone mass loss, so there, sort of just by plugging the leak, it's not going to happen. You need something which is anabolic, which can fill up the water, and then later on you can plug the leak. So this is a general scenario which we need to consider while treating osteoporosis. There are a lot of ifs and buts in these two scenarios, but for the simplicity of it, I prefer showing this diagram so that it makes the life easy and it helps you to make a clinical decision. So based on this, we know there are two types of medicines: anti-resorptives and anabolic. So anti-resorptives are the medicine which would plug the leak, which means which stop the bone loss or osteoclastic activity. And anabolic are the one which would sort of build up the bone, which are anabolic, which sort of increase the bone formation and would improve your stock. So anti-resorptives medicines include sort of calcium and vitamin D. It includes hormone replacement therapy, selective estrogen receptor modulators, calcitonin, bisphosphonate, denosumab, and the other new drugs. So calcium and vitamin D is very basic thing which all of us give to our patients. There is a recommended dietary intake for calcium. This is the total intake. So the tablet plus oral intake should be this much. It's not that you should have to give tablets of 1300 milligram. You have to give overall this amount. So look at this. A male has an sort of approximately a requirement for 1000 milligrams and a female 1200 milligrams. So you have to also consider how much is the patient taking in diet, especially a patient is taking non-veg food, and also the calcium intake is usually better than somebody who is a complete vegan, who will not even take milk also, or who will not take curd or even animal products also. Now, there are two types of calcium tablets. One come as a calcium carbonate or tribasic calcium phosphate, or the other are the citrate or maleate based prescription formulations. So the first ones need to be given on an empty stomach. Empty stomach means food interferes with the absorption. So you have to preferably give it 2 hours after the dinner, and so that the patient is not eating anything after that which could absorb. Antacids and all interfere with the absorption of these formulations. You should remember that not more than 500 to 600 milligram of elemental calcium can get absorbed at one time. It is beyond the intestinal threshold. So if a patient is taking calcium tablet morning, evening of 500 milligram, and he asks you that, Doctor, मैं ये दोनों tablets इकट्ठे खा लूं? The answer to that is no, because it will not get absorbed. So you have to consider that also. The citrate formulations are independent of the antacids. They are not hindered by the presence of food, so you can give them at any point of time. And they are also slightly protective to calcium oxalate crystal formulations. So usually they are better, but again, it's sort of, you have to make a clinical decision because the cost is more in these formulations. Vitamin D is an essential vitamin. We all know that. Many people ask us about sunlight and all. So you have to tell them that it's only when the shadow is shorter than your body, which is around 11 to 2 in the afternoon, and your 40% body area is exposed, and you get a 10 to 15 minutes of exposure, then only adequate vitamin D is formed. So there is a general tendency that we all are deficient in vitamin D, because we do not get this level of exposure. Walking in the morning sun or evening sun does not form the vitamin D in body. It is not adequate to have that level of penetration that it can convert the cholesterol into the vitamin D. Another important question regarding vitamin D is that, is injectable better? Unless there is some malabsorption, injectable is not better. The chances of toxicity are higher in injection. And if you see this diagram, you see if you give 6 lakh units oral stat versus IM, the peak concentration in blood is achieved earlier by oral formulation than by injectable formulation. Rather, injectable keeps on increasing over 4-month period and can lead to toxicity. So oral is always better. Weekly doses are better than one-time doses, because they slowly replenish the vitamin D. Do not prescribe 3-6 injections to your patients. If you're giving a vitamin D injection 6 lakhs unit, one injection should be good enough for 6 months. Don't repeat these injections. It leads to toxicity. Patient develop kidney stones and they'll end up with urologists for their kidney stone removal. Do not use formulations which contain calcitriol or alpha calcidol. It's an activated vitamin D. It has got specific uses. It is used in CKD patients because they cannot 1-hydroxylate their 25-hydroxy vitamin D and cannot activate it. So they need this formulation, or in certain diseases, but do not use this formulation because again, this will cause hypercalcemia and can lead to metastatic calcification or can lead to urinary stones. Recheck the vitamin D at 6 to 12 months interval. Maintenance therapy should be 1000 units a day, or to simplify, you can tell them to take 60,000 international units once a month. That should be good enough. That is good enough to maintain the vitamin D levels. The other anti-resorptive which we use clinically is calcitonin. As a salmon calcitonin we use as a nasal spray. It's not an anti-resorptive. It has got again specific indications. It is used to treat hypercalcemia because of metastasis. It is used to treat hypercalcemia because of recumbency, and these are the indications. Salmon calcitonin also has got some mechanism by the morphine receptors to reduce the pain in acute fracture. So we sometimes use them for same, but this medicine is not recommended as an anti-osteoporotic. Bisphosphonates are probably the cheapest available, and they are the easiest available, and we use them a lot. The sorry, the commonly used bisphosphonates are alendronate, risedronate, zoledronic acid, and we also use ibandronate. So before you start bisphosphonates, the patient should have a normal renal function. You cannot use them beyond stage 3 CKD, which means the creatinine clearance or EGFR should not be less than 30-35 ml in alendronate, zoledronate. Vitamin D should be normal. Oral bisphosphonates may have some oral GI issues. Their absorption is very less. Only less than 1% of dose is absorbed. So you have to give them empty stomach with full glass of water, and patient does not have to eat anything for 45 minutes so that the drug can get absorbed. Now have a look at this table. There are 3 points I want to highlight here. Is that alendronate, which is the most commonly used bisphosphonate, is not recommended for prevention of glucocorticoid-induced osteoporosis, which means patient on steroids is not a sort of candidate to be used for protection. Neither is ibandronate, which is given as once a month. Ibandronate is also not recommended for treatment in men. So you have to consider these. So if you want to give glucocorticoid protection, you can use risedronate, or you can use an injectable one if you want to use it, but don't use alendronate because it's not recommended. Now spine, all the drugs act on spine. Spine is very lucky in this sense, but the hip, only zoledronate works. So if you have got a patient who has got a hip fracture and you want to treat osteoporosis, and you're giving the other drugs which do not act well on hip, then the better preferred option is to give a zoledronate or an other injectable one which would work on hip, rather than giving these drugs which would not be able to protect them. We usually stop bisphosphonates after 4 to 5 years because we give a drug holiday for many reasons, because there are complications which can happen, like which one of them is we know is the osteonecrosis of jaw. It's a raw area which is present on the jaw with non-healing sort of an ulcer and can get very bad. So patients after 3 to 4 years of alendronate therapy should undergo dental checkup once every 6 months or as per clinical indication to evaluate this thing. Usually these things are seen more in patients who are on chemotherapy because the oncologists use these medicines in a very high dose as compared to osteoporosis. So you see more often these complications over there rather than in osteoporosis scenario, but you should know these complications. The other one is atypical fracture. So if a patient on bisphosphonate therapy starts complaining of hip pain, you do an X-ray and you see a unicortical sort of a fracture like this. So it's an atypical subtrochanteric fracture, happens because of failure of remodeling, and the risk increases with time. So the risk after 2 years becomes 10 times and the risk after 5 years becomes 50 times. So you may ask that if this therapy is itself going to cause a fracture, then what is the point of giving this? The answer is that for every this incident which happens, it protects hundreds and thousands of fractures which would have otherwise happened, which is the advantage of these medications. Now, so if you get these atypical fractures, there's an algorithm for that. Incomplete asymptomatic fractures, you can switch to teriparatide and let it heal if it's painful, or it's a complete fracture, then you need to fix it. So this you should remember. And now to the Denosumab, which is a monoclonal antibody against rank ligand. And rank we know is sort of a ligand which sits on a receptor on a pre-osteoclast. And when this ligand gets attached to the receptor, it matures it into an active osteoclast, which causes resorption. So if you are able to block this sort of ligand, then you can prevent this osteoclast from maturing and it will be an anti-resorptive. It's now approved for 10 years. It's more renal friendly, so you can use it in stage 4 CKD, but there is an increased risk of hypocalcemia, so you have to take care of that. Stage 5 CKD, which means your eGFR is less than 15, there is no recommended therapy for osteoporosis, and you have to give the alpha calcidol and calcium tablets only. We give it as dose of 60 milligram every 6 monthly. It has to be time bound. You should not sort of delay the next injection, because suddenly after 6 months, you see this starts dropping, the efficacy starts dropping and the effect is lost. So you need to give it in time. You cannot stop Denosumab suddenly, because it sometimes leads to increase bone resorption or bone loss, which can cause new fractures in the spine. So you should take care of this, that whenever you have to discontinue it, either you taper off the Denosumab or you switch over to Bisphosphonate for a year and then you stop it. And Denosumab is also now recommended in glucocorticoid-induced osteoporosis. It's approved in India in January 21. So if you have a patient where you are starting high-dose steroids and it's going to go for long, it's a high-risk patient, then Denosumab is now a treatment modality in these. Anabolic agents, there are many names, but I will limit to teriparatide, which is the most commonly used. It's a PTH analog. You may want to sort of ask that this PTH analog, how does it form how does it form an anabolic activity? So PTH, basically a pulse therapy of PTH stimulates osteoblasts and that leads to bone formation. It is recommended to be given for up to 24 months, used as once during lifetime therapy as a daily 20 microgram self-administered dose. There were some concerns of malignancy in animal models, but they were growing rats with open epiphysis. There was incidence of osteosarcoma, but it has not translated into clinical practice in adults, because we use it in adults who are elderly. We don't use it in patients who have open epiphysis. So that has not seen clinically. You can monitor it using P1NP. Hypercalcemia is a major concern in these patients. So if you are patient, you can check the serum calcium levels in these patients if they're having symptoms, and you can reduce the dose of calcium tablet or stop the calcium tablet also for some time, switch to natural sources of calcium to tackle these things. Very rarely there will be a situation where you need to stop this teriparatide, otherwise it is very well tolerated. It is recommended to be treated in post-menopausal osteoporosis also, in senile as well as in glucocorticoid-induced osteoporosis. And last, combination therapy, teriparatide and Denosumab can be combined together, and they have been shown that they give the best possible results in bone resorption when bone osteoporosis whenever you use them in combined therapy. So you start teriparatide and Denosumab together, and then later on you continue with Denosumab, because teriparatide you have to stop at 2 years. Another anabolic is abaloparatide, but we'll leave it over here. Rohan, before I go to the surgical part of the spine osteoporosis, any questions do you want to ask?
Sir, the residents are here, so I'll just ask them if they are. Varun, do you have any question? Tarini, Manan, Dr. Harshvardhan, Irfan, anybody? If you all have any doubts regarding the medical management. Okay, so sir, we have a question. Yes, Tarini, please tell me.
So what are the prerequisites for starting Denosumab therapy for osteoporosis?
So the prerequisites for any anti-resorptive are that your vitamin D should be normal. Second is that your creatinine function, as I said, in bisphosphonates, it has to be up to stage 3, and in Denosumab, you can still use it up to stage 4 CKD. So if you have a very this thing called as EGFR calculator, if you type it on Google, you will get a EGFR calculator. You put in the creatinine and the patient age and sex and all, and you get a that EGFR. So based on that, you can categorize the sort of CKD stage, the kidney stage. So Denosumab stage 4 CKD up to you can use. Vitamin D should be normal, and you should give them adequate vitamin D daily, at least 1000 international units daily, and around 1000 to 1200 milligram of calcium daily. So these are the main things which you need to ensure before you start the patient on Denosumab. Again, it's a long-term therapy. There is no point of giving it for 6 months or 1 year. You have to commit to the patient to be used for at least 5 years, and then take a call to be extended to another 5 or so.
So just adding to this, sir, my doubt would be how often are you now incorporating, say, Denosumab in your practice? Like when on comparing bisphosphonates for those who range from like say minus 1.0 to minus 2.5 BMD, like T-score.
So again, Rohan, as we discussed that the T-score is not the only thing. We need to have a look at a clinical scenario. So you'll be surprised that a lot of people prefer taking this Denosumab as compared to oral bisphosphonates or these things, because it can be now administered as a home setting also. I prefer giving the first dose in hospital, observe for 30 minutes, and then nowadays people are taking the injection within their home environment also. The only factor till now is cost, which because now the Indian companies are coming is also reducing. So I believe in the coming time, it's going to increase even further. And it's a good drug. You can give it for a longer time. Your chances of efficacy is better than bisphosphonates.
Yeah.
And the best part is that you can combine it with teriparatide if you need to do it.
Yes. In the effectivity is still the same with, reduced scheduling of the drugs on comparing bisphosphonates. Yeah. Thank you, sir. Anybody else, if they want to ask any questions before we proceed to the surgical management? Okay, Manan, please go ahead.
Sir,
Dr. Manan.
Sir,
Yeah.
can you please guide us about protocol for OVCF patient? I mean, when should we start mobilizing patient, and is there any role of breast if we are managing the patient conservatively, sir?
So once you have a patient of a osteoporotic spine fracture, again, the patient may present to you with any clinical scenario, like they may present to you completely bedridden with just a first time sort of situation where they have some pain and all. So you have to take the clinical call. A fresh osteoporotic fracture, usually I recommend a complete bed rest for a week. And after that, we usually give them brace, ash brace, I prefer, or a Taylor's brace if the patient is not sort of comfortable with ash brace. And we at least aim for bed chair mobilization, like sort of we try to make them sit on a chair alongside the bed. Usually at 3 weeks, I would think of them going to the washroom to sort of have a go to the washroom for their bare necessities and have meals while sitting. And between 6 to 12 weeks is usually when you make them more mobile and more independent. Again, all of this needs to be monitored clinically. Any increase in pain, any increase in weakness, numbness, or any appearance of weakness, numbness in the legs, or any slightest urinary sort of a problem, because most of these fractures are at the D12L1 level, which is the conus level. Any slight sort of hesitancy in urination or increased frequency needs to be looked with very high suspicion.
Yes,
Thank you, sir.
Thank you. So we can go to the management part, I think.
Yeah, so I'll just quickly go through this. So
yeah.
So the osteoporotic spine fractures, they are one of the commonest fractures, osteoporotic fractures you encounter. And the whole thing stands on a very poor base because everybody has got a different way of treating the fractures. And most of the time it works because sort of nature is kind. And sometimes we land up in very difficult situation with these patients. So what happens when the patient has an insufficiency fracture? Let's have a look at this 60-year-old female who had a trivial fall and had these 2 fractures in the spine, which you can see over here. You see the MRI can show that this one which was looking bad on the X-ray is actually the old fracture, and the one lower one is the new one because that is showing marrow edema. So you see over a period of time, the 6 weeks, 12 weeks, the other fracture collapses. 6 months, it sort of starts forming a stabilizing osteophyte anteriorly. And at the end of 1 year, this has incorporated as one mass and it has healed. So this is what happens to most of the osteoporotic fractures. All you need to do them is protect them from having a neurological deficit. But not all of them heal. They may go into pseudoarthrosis or instability and then suffer loss of function. So the surgical strategies in these situations come as a cement augmentation procedure, which is a vertebroplasty or kyphoplasty, a cement augmentation or an anterior procedure with a fixation, or you collapse the segment and sort of form a vertebra plana and fix it, or you may sometimes need to do a bigger procedure and give an anterior reconstruction to support your construct. Now have a look at this patient. Elderly patient had a fall. This L4 is old fracture. This is the new one. And you do a vertebroplasty in this patient and it works for the patient. The other procedure is balloon kyphoplasty, which actually is an expensive vertebroplasty. So what it does is that it goes in through the pedicle. It inflates a balloon, which is believed that it will restore the vertebral height, and you fill a high viscosity cement into this cavity which you have created. It decreases the chances of cement leakage because in vertebroplasty, we use low viscosity cement under slightly higher pressure, whereas this is high viscosity under lower pressure. But does it translate into a clinical advantage? Well, we don't know, but the procedure is there. So you have a pressure transducer. So you inflate the pressure transducer like this, and you go into the vertebral body, you inflate this transducer, increase the height, and then you fill in that area with the vertebral cement. And this is something what it would look like. Now, the problem with these procedures is that the cement is too hard. So we are placing a pile of stone between cushions, or it's a pebble in the shoe. So we are yet to find an ideal cement which would match the elasticity of the bone. But once you do this, there is always a chance that the bone around it will erode and it will lead to a bigger problem. Let's see with this patient who had a vertebral fracture above a fixation level. He did a vertebroplasty, but unfortunately it collapsed because the cement was too hard for the bone. Probably this cement was too much put, could have been less, and it needed a bigger reconstruction to sort of support the construct. Another patient which has got a L4 fracture, and you don't want to do a standalone vertebroplasty because you see this thing protruding towards the canal and you are worried. So what you can do is you can do a vertebroplasty and protect it with the screws. So these are the cement augmented screws which are there. So cement can be injected through the screws and that gives additional purchase into the bone. So to tackle these osteoporotic spines, you need to put more screws to fix the fracture. You can use cement augmented screws. You can use bicortical purchase. It's a clinical, slightly technically demanding thing. You can use hooks because lamina have better hold than the cancellous body of the vertebral, cancellous bone of the vertebral body, or you can use sublaminar wiring. So pedicle screws offer 3-column fixation, but the hooks and wires offer only 1 column, but that column is the strongest. And that is what works in osteoporotic spines. So now you have a dual thread screw wherein you have a cortical pitch, which is a thinner sort of a pitch. And you have a cancellous pitch anteriorly, which is called as a dual thread screw. So you can use that. You can use longer screws because they give more pull-out strength. And in thoracic, you can use a straightforward trajectory because this gives better sort of a hold, because this is closer to this end plate bone, which is thinner, rather than this, which will be in the hollow of the vertebral body. So these are the common tricks you do to salvage. Again, you try to angulate the screws more medially, because more medially they are directed, the better pull-out strength they have. You can use larger diameter screws, whatever the pedicle can accommodate, because these pedicles are usually hollow and narrow, so you are able to put larger diameter screws. Let's have a look at this lady who has got 2 osteoporotic fractures, went into non-healing, and we have done 2-level vertebroplasty, and we have used cement augmented screws to sort of augment our fixation. And this is at the end of 1 year. A procedure which I like very much is a cage plasty, which sort of is a augmentation of the vertebral body with an intra-body cage, like a Tilif cage, which you put inside the vertebral body. And this you can see a cage put anteriorly, which gives a good anterior column support. You don't need to take down this vertebral body to provide an anterior support. Within that vertebral body, you can have a support. And this is the 1-year X-ray where you can see this fracture has healed very well. Another similar case with a cage plasty, you can see the intra-body cage, which is put inside. And if it fails to heal and there's a gross deficit, then you might sometimes need to put a sort of a anterior support between the end plate and the other bone, taking that disc also out. And this is something what happens. And last worst case scenario, when everything fails, your screws are backing out, there is nothing what you can do because the bones are so osteoporotic. Your rescuer comes as the heart shield, which is the old age technique of sublaminar wiring, because these wires have got better hold and they can sort of help the bone collapse in a more controlled way. They are less sort of stiff than the pedicles to construct, and they can help you salvage an unsalvageable situation. If your bone density is very, very bad, which means an absolute BMD of 0.3 grams per centimeter square, it's not recommended to do a pedicle screw fixation. You should only do wiring or taping of this. So to conclude the management of these fractures, if the fracture goes into non-union, you have a cement augmented procedure in a limited scenario, because most of the times we are now moving away with these standalone cementing procedures. I rarely ever do a standalone cementing procedure now. Or you can do a cementing plus fixation. If there is a neurological deficit, then you can reconstruct the anterior column by doing a cage plasty along with a decompression of the same stage. Or you can do a interbody reconstruction, like I showed you, where the disc also had to be removed along with the part of the vertebral body. Or you can do a sort of a small subtraction osteotomy to collapse and join the 2 bone fragments, collapse that Kumal's lesion or that empty space in between, so that those 2 bone on bone can heal and you don't need to put anything anteriorly. Thank you very much.
So thank you so much, sir, yet again for putting up a great talk, and all those tabular algorithmic explanations that you had given would really be helpful to our residents. I would just request 1 or 2 quick questions from Varun, maybe Tarini.
Sir, I wanted to ask, sir, when do you decide in a patient with an osteoporotic vertebral fracture who has no neurodeficit, either to conserve it or to, fix it with some, do an instrumentation, or you can when to go from a conservative management to an operative management?
Sir, you're muted, I think.
Yeah, I'm sorry. So usually you need to give these patients 3 to 6 weeks of conservative trial before you can conclude that they are sort of not responding to the therapy, because most of the patients would become better in this time frame. If the patient has got severe severe pain, he or she is unable to sort of make her cut out of the bed even at 3 weeks, and absolutely there is no movement, then even if they don't have a neurological deficit, the risk of keeping them in bed is very, very high, because they will have some hypostatic pneumonia, some DVT, some urine infection. They are at very high risk. So if you are able to mobilize them, you can hold on. But any patient who does not have a neurological deficit and is still completely bedridden at 3 weeks, I would offer that patient a surgery.
Okay, sir. And sir, also I wanted to know, sir, when you're going for a stabilization, how do you decide how many levels above and below the fracture you want to fix?
See, in osteoporotic, it is at least 2 levels above and 2 levels below. What we are discussing is, do we need to go 3 levels or not? So if the bone density is not very bad, like it's not minus 4.5, minus 5, something like that, and I am doing an anterior reconstruction like a cage plasty, which I showed you, I
Yes,
think
sir.
2 above and 2 down should hold. Usually I prefer 2 down and 3 above, because in thoracic it does not matter even if you go 1 level higher, because it's relatively sort of stiff part of the spine.
Yes,
But
sir.
lower down you can do 2 levels. But if it is grossly osteoporotic, you are not sure of the anterior reconstruction, then it is preferable to do 3 level up and 3 level down. Obviously, I would not want to end my these sort of fixations at the sacrum level or just at L5 also.
Yes, sir. Okay, sir. Thank you, sir.
Thank you, sir. Thank you again for this wonderful class, and thank you for sparing time out and taking your time out for the postgraduates. And yeah, I think Rishi, we are done.
Thank you, sir.
Yeah, thank you, Rohan. Thank you, Rishi, and thank you all the our students who joined. I hope it benefits you to some extent, and this will sort of help you in your practice in the coming days, whatever you'll be doing. Thank you very much.
Thank you, sir.